Gracias. And now I will speak English. I have very little Spanish. My name is Erin Ross, and I'm here with my colleague Sarah Smith-Simpson, and I will start, and then Sarah will come in the middle, and then I'll wrap up for today. This is a very, very big honor for me to come and be able to speak to physicians and to share some of what we've learned over the years. So I work with a colleague, Dr. Kay Toomey, and she and I teach a program that's really designed more for children who are not eating anything or eating very little, and you will hear a little bit about that. But we also work with families who have fairly typically developing children who are not eating healthy. And so we are also going to spend a lot of time talking about that. So the disclosures, I do work with Nestle, and you will hear more about the developmental panel from Dr. Smith-Simpson. And then, as I just said, I present a course to therapists on how do you work with children who don't eat. And then Dr. Smith-Simpson is a principal scientist at Nestle. So today we're going to be trying to address these questions. One, talking about what do we know about the children who are not eating or not eating enough or eating too much. Then we're going to talk about how children learn how to eat, because one thing that many families do not know, many physicians do not really understand, is that the development of the child directly affects their ability to eat and what they eat. And so that's the next part. And then we're going to talk at the end about practical ideas to tell parents to help their children eat more healthy foods, eat more age-appropriate foods, or eat more food in general. So let's start with talking about the population that this talk is designed to really address. When we think about growth problems here and everywhere, we all have a large number of babies born preterm. So preterm infants do have a difficult time with good growth, and that can also impact them after they go home. We know that in Mexico there have been a couple of studies looking at the amount of poor nutrition, and so you see for both undernutrition and overnutrition, overweight, stunting in children less than 5 years old has been coming down, but still is relatively high. We would like children to have better linear growth. Wasting was much lower. You see about 5% of the population. Overweight is starting to climb up a little bit, and certainly in the US, this is a bigger problem, children who are overweight. So why am I bringing up overweight children when we're talking about helping parents teach their children how to eat? Because we know that many children who have some difficulty with eating may start to eat easy-to-eat foods. And easy-to-eat foods often are junk foods. They are the high-energy, low-nutrient foods. Foods like vegetables, meats, and fruits are the most challenging to eat for children who have any kind of sensory difficulties or oral motor difficulties, and we'll talk about why as we go through this course. So we actually are seeing more children who are overweight in our clinic. We know that this is a more recent study that was published that shows similar outcomes than we just talked about. We are going to spend, I think, more time talking about children with what we call feeding problems. So they are eating, but they're not eating a wide variety, or eating is a challenge for them. Parents may be fighting with them a lot, or they're not eating healthy foods. And so we know that across the world, every country has children who are not eating well. This is a study from England. You see very high numbers in this study. And being difficult to feed, you see is increasing as the child is getting older, up until about 14 to 15% as they are going into preschool. We know that children who have feeding problems often are struggling with transitioning across the food textures that we expect our children to learn to eat across the first 2 years of life. That's why we're going to talk about development across the first 2 years of life. We know that preterm babies, all preterm babies, appear to have more problems with appetite. They have low appetite. They avoid eating. They're not very interested in eating. And this is true whether you are a early born preterm baby, so a baby born at 32, 33 weeks or younger, or if you are a late preterm. So even babies who are born at 35 and 36 weeks, post-conceptional age, have an increased risk of having avoidant feeding behaviors and low appetite. And part of that, again, is related to preterm infant development. We also know that there's another group of children that are at very, very high risk of feeding problems, and that is the population on the autism spectrum. And so almost 2/3 of those children will be struggling with eating a wide variety of food. And in fact, one of the things we know about this population is that they tend to eliminate foods over time. So maybe at 2 years of age, they were eating 10 foods. At 3 years of age, they may be eating 6 or 7 foods. At 4 years of age, they may be eating 3 or 4 foods, and relying really on only a couple of foods to grow, to meet their nutrition. And so that's another group that we see a lot of in our practice. Using data from your NSNOT study in 2012, in the birth to 2 year age range, you see that a number of children are not really eating any fruit or vegetables between this age range. So 40% of the children in this study did not have any report of fruit or vegetable intake, and 30% of children were not eating any animal products. Remember what I said, fruits, vegetables, and meats are the hardest from a development standpoint to eat. It's a lot easier to mash cookies and French fries and chicken nuggets. I don't know if that's a big thing here, but in the US, chicken nuggets seem to be a big food. So why is it that every country struggles with this? And that's one thing that I was sharing before the talk. Kay and I speak all over the world. We've spoken in the Far East, we've spoken in Australia, Ireland, England, Chile, Argentina. We all have children who are not eating well. And so we're going to start talking about why children aren't eating and how children learn to eat. So the key with eating and feeding problems is that many of us think that children just eat. And so when a child isn't eating, we need to think about where do we start. And certainly for all of you, the family comes to you and you are being asked, okay, how do I get him to eat fruits and vegetables? And so this is the way we think in our clinic. The first is we know certainly that children who are struggling to eat a wide variety of age-appropriate foods, one of the biggest reasons is because they have medical issues. So children who've had nasogastric tubes or gastrostomy tubes, children with GI dysfunction, that is actually the #1 risk factor for long-term feeding problems. Respiratory difficulties, those children are at high risk. Cardiac and neurologic, those are your top 4. And so we'll talk about that a little bit more in just a few minutes. Muscles, all of our muscles have to work together to eat an age-appropriate diet. When you're a baby, you don't need as much coordination across all of your gross motor, fine motor, and oral motor skills. But as you start to transition to sitting up, to feeding yourself, the gross motor and the fine motor skills become more and more influencing factors. So we're going to be talking about the developmental progression. Your sensory system is integrally involved. And so we know that we all have at least 5 sensory systems, right? We have what a food looks like, smells like, tastes, the touch, and the sound of food inside your head. So we have learned this from working with children on the autism spectrum. There are children on the autism spectrum who have said to us, okay, cover your ears. When I bite this, it's going to be really loud. It could hurt your ears. Now, to you and I, we think that doesn't make any sense. But for a child whose sensory system is really reactive, even the sound of food makes a big difference. But there are other things that we have to think about that are sensory inputs. One of them is hunger. Hunger, satiety, knowing when to eat, when to stop eating. These are sensory inputs in part. We know that there are other influencing factors with appetite, but the sense of interoception is often not working correctly with the children that I work with. And then the sense of balance and the sense of proprioception. And we'll talk about all of those when we talk more in depth. Learning. We're actually going to start the developmental milestones talk by talking about how children learn. Because children either learn to eat a limited number of foods, learn to avoid foods, or learn to avoid all foods. And so we want to talk about how they learn so that we can change what they're learning in just how we interact with them during meal times. Nutritional status. We won't spend as much time on this. Certainly this is a main focus of this Congress and much of the other work. But we know that what you're eating and your micronutrients can affect your energy to eat, your appetite as well. Things like iron and iron deficiency certainly is something that we see in many, many countries. Overall development, that's what we're going to be spending most of our time on. And then the environment. And the environment is what most people historically have focused on, what the parents are doing wrong. And we're going to talk about why parents do things that are not helpful and how to help them be better teachers. But it is important to remember it's only one of 7 things we need to think about. And so that's why we're going to actually spend more time on the other areas first. So the other thing that we're going to briefly talk about is that across all of our countries, we have ideas or myths about eating. And these myths actually get in our way. And I was sharing that before the conference too, that a big myth is that children just are born knowing how to eat a healthy diet. And so these are the ones that we find wherever we go. In some form or another, these are found in every country we have spoken to so far. Myth number 1, eating is your body's number 1 priority. The way people talk about this is they'll say things like, well, don't feed him his favorite food and he will eat the healthy food. And the problem is that there is a group of children who don't have the skill to eat a healthy diet. And those children, if the parent says do not, or the parent says I will not give you your favorite cookie, the child will in fact not eat and will not grow. So the key is children's number one priority is not eating. First is feeling good. So if eating makes me feel sick, I'm going to stop eating. If I'm coughing or choking when I'm eating, I'm going to stop eating. They think about now. They don't think about, I need to do this because it's good for me. Myth number 2 is similar. Eating is instinctive. We're born knowing how to do it, and so there is this drive. And we know that's true for about the first 2 months of age. 2 months. Where a healthy term baby is born with a sucking, swallowing, breathing ability, and we don't have to teach them how to go to mother's breast or to take a bottle. However, you're going to see when we talk about development that around 2 to 4 months of age, things change. And the primitive motor responses that have been helping the baby eat are going to go away. And more sophisticated motor abilities will start to come on board so that we can start learning how to take in baby food, pureed food, and transition. And so, yes, this is true for a very short period of time, but during that time when the body is helping with motor responses that are very primitive, the baby needs to be learning that eating is fun and eating is something they can do without feeling bad. Myth number 3, eating is easy. What's the big deal? We all do it. and what we need to think about is that I believe that most of us, at least in this room, are pretty healthy. Okay? But our children that we're going to be talking about may have one little problem in one little area that's making it difficult for them. So we're going to be thinking about how complex eating is. Myth number 4, eating is a 2-step process. You sit down, you eat. Now, have any of you used the strategy telling parents, tell your child they have to just take a bite? Just take a bite. It's in the U.S. they say it's a no thank you bite. Okay? The problem is that when you tell a child you have to take a bite, you are actually starting the learning process at eating, and that is many, many steps down the road. So let me put that idea in your head. We're going to come back and we're going to talk about that more. We talk about 32 steps to eating. So if you put something in front of your child and they put it in their mouth, chew it up and swallow it, great. But if you put something down in front of your child and they say, I don't like it, we have strategies we teach our parents to use that are starting with looking at the food and talking about the food and helping the child move from no and into learning. And so that's where we're going this afternoon. Myth number 5, it's not okay to play with your food. We're all pediatricians or have pediatric backgrounds in this room. And we know children learn best when they play. When they're having fun, that's when they're learning the most. And so one of the things we're going to be doing is taking that stress away and thinking about meal times as a time to use play and ideas to teach about food. So we don't teach our children just to play with their food, but we teach them how to eat food using play strategies. And so we'll talk about that a little bit more. Myth number 6, if a child's hungry enough, they'll eat. They won't starve themselves. Well, we know from the data that I just showed you that there is a small portion of children, and different countries have different levels, of children who are not eating enough. And so we know that if you don't have the skill, it doesn't matter how hungry you are, you will not typically be meeting your nutritional needs, or you will be meeting it using liquid products when you are old enough to be eating actual food. Myth number 7, children only need to sit down and eat 3 times a day. We teach our families that meals and snacks are the same. They are times to teach about food. And so we give our parents structure to use to help their children learn to eat. But for us, meals and snacks have some requirements. And those requirements include a protein, a starch, a fruit, and a vegetable every time you sit down with your child to eat. So we'll talk about how do we work with our families to do that, because in all of our countries, parents are not home, they're really busy, they're eating in the car. So we'll talk about how do we help parents with that. Myth number 8, children have either a behavior or an organic problem. And I think most of us understand that there is a connection between the two. In the US, what we're finding is that there are people who believe if the child doesn't have an organic problem now, so as an example, they had reflux as a baby, but now they're 4 years old, so if they are not eating well, it's because they have a behavior problem. We don't see it that way. We see children who had a medical problem that is now corrected also learned during that time that eating wasn't working. So we talk about learned avoidance behaviors instead of just behaviors. Myth number 9, certain foods are eaten only at specified times of the day and only certain foods are healthy for you. We try to help parents understand 2 things. 1, food is just food. Eggs have the same nutritional value at breakfast, at lunch, and at dinner. So when we think in our head that they are only okay for breakfast, if you think about how easy it is from an oral motor standpoint to eat eggs and how hard it is from an oral motor standpoint to eat meat, thinking about how can we look for complete nutrition sources to improve the diet of children that meet their oral motor or their sensory needs. And so we're going to be talking about that quite a bit. We want our parents to think about the nutritional value of foods, not junk food, healthy food, because the kids we're talking about only eat junk food, right? And so it already starts the parents off thinking that there's something wrong with their child when we use words like junk food. And yes, there are foods with high nutritional value and low nutritional value. But we're going to start with what the child eats, and we're going to build in nutritional options. And then myth number 10, meal times are a proper social occasion. Children should sit down, eat, be very neat, and nice and quiet. We're going to ask families to be teachers during meal times. So again, if your child just eats, you don't have to worry about that. Then you can focus on manners. But if you are trying to help your child learn to eat new vegetables, new fruits, new meats, we need to help your child through talking to them and teaching them. And these are all just as difficult to do with the families that I work with in the US as it is to work with your families. Because all of our families are busy. They all think, oh, you know, everyone else's child just eats. So we're going to talk about that's not actually true. Okay, so let's talk about learning. This is how children are, this is the job of childhood, isn't it? Learning about everything. They are curious creatures, which works to our advantage when we start to understand why they're not wanting to eat food. So where do these avoidance behaviors come from? So we're going to actually go back in time to Psychology 101 and think about how these things that we all learned way back then apply to eating. Children learn through classical conditioning, operant conditioning, and actually through social role modeling, which we will talk about later. But the 2 that we're going to talk about that influence avoidance behaviors are classical conditioning and operant conditioning. So classical conditioning is Pavlov's dog. So here is a cartoon. It says, "Hey Earl, watch this." And one of the dogs rings a bell, and Pavlov's dog is starting to salivate. So does this ring a bell for any of you? So let me just briefly remind you, in Pavlov's experiment in 1927, when he published this, it was quite radical. Now we have verified using functional MRI that what he thought was happening actually happens. So in dogs, you have something called unconditioned stimulus. That is just something that happens in the world. It's just there. So food, as an example. Unconditioned response is a body-based response. It's something that your body does. You're born doing it, okay? The CS in step 2 is a conditioned stimulus. A conditioned stimulus is something that is now going to be conditioned or taught to be associated. So what Pavlov did is he showed the dog the food, they salivated. Then he started to show the dog the food and rang the bell, and the dog was salivating initially to the food. But with repeated exposures of ringing the bell every time they saw the dog food, the dog learned that when the bell rang, he salivated. You didn't have to show him the food anymore, okay? Is this, you guys remembering any of that? I don't know actually how much psychology learning you guys are taught. Sorry. Okay, so now with functional MRI, we can see that when you ring the bell, the food part of the brain, the bell auditory part of the brain, and hunger part of the brain all light up together, even if there's no food present. So why do we talk about this with children and eating? Because much of what gets in the child's way of learning to eat a wide variety of foods has been negative conditioning. So if a child is experiencing nausea, the body's response to nausea is appetite suppression, okay? If you are in pain or discomfort, let's say you accidentally put your hand on a hot stove, your body's response is to remove your hand. You don't think about it, it is an automatic response. Okay? The problem is many of our children have had to eat when they're nauseous or had to eat when they've been in pain or discomfort, thinking coughing, choking, anything like that that's happening while they're eating. And they have learned that food is something to be escaped from or to turn off their appetite. So when I don't work with children who don't eat, I work in the intensive care nursery. And I work with babies who have medical conditions, who have nasogastric tubes. And my job is to help them move off of the nasogastric tube and onto oral feeding. And so many of the babies that I work with are having a lot of painful things happening to them when they're in the intensive care nursery. So that's part of what's happening. The other way that little children learn is through operant conditioning, praise and punishment. Okay? So when a behavior is followed by something good, desirable to the child, okay, they're going to do more of that behavior. When the behavior is followed by an undesirable consequence, there will be less of that behavior. So how does this influence eating? If you're eating and someone is talking to you and being really lovely with you and all of the emotions around the table are really positive, that would help you to eat more because that's a desirable consequence. If a little child is eating and someone imitates them, that is highly desirable to a child, especially under the age of 3 or 4. Okay? Don't try to do that with an adolescent. They don't like it. Okay? So desirable to the child is what we have to remember. Okay? That will increase eating, and you will see there have been some very nice studies that show when parents eat with their child eats more of the foods the parent is eating. However, it also can work against us. If you refuse to eat something as a child and you get a lot of attention for refusing to eat that food, that is actually increasing the child's likelihood that they will refuse it more. Okay? So one of the things that happens as parents is that we sometimes don't pay attention to our children until they do something bad, and then we correct them. So in practical strategies, we're going to talk about how do we encourage our children when they're doing what we want, because that is a very effective strategy. And we want to teach parents to stop only paying attention when their child refuses. The other way that this influences, if a child is eating and they have a choking episode, they are more likely to stop eating or refuse that food, because choking is a very aversive experience. If they are eating and they're getting a lot of pressure because the parent is worried about their weight, the more worried the parent is about the child's weight, the more the parent pressures the child. And then we have a negative learning cycle. So that's another one. I always say I like to use analogies for adults so that we all really get it. And so as another example that is sort of classical and sort of operant is if you've ever gone to a restaurant and maybe everyone was telling you what a great restaurant it was, but for whatever reason, after you went to the restaurant, you were violently sick. Okay? It may have nothing to do with the restaurant, but are you likely to go back there? No. We are pretty quick to make judgments based on our own learning and our own experience. So children are the same way, but we kind of forget that. So what we need to think about is that there are a lot of influencing factors that are at play. The development of flavor and the acceptance of novel foods is achieved through a complex interaction between biological factors and environmental factors. We may not be able to change biological factors, but understanding the biological factors that help children learn to be good eaters, we're going to touch on, and we're really going to help parents with the environmental influences. So one of the other pieces then that happens is something called habituation. So habituation is how do you get over kind of that initial, I don't know about this is new to me. It is actually a combination of classical and operant conditioning. So, for instance, when you offer a baby or a young child something new, typically their first reaction is a rejection because it's new. They've never had it before. So the face of the baby might be something like that. The child who learns that they can say no may just look at it and say no. With operant, what we know is that you can counteract that initial rejection by understanding that when a child gets a similar or somewhat familiar taste followed by a desirable consequence, they're more likely to try. So the key behind offering your children lots of opportunities to try new foods is that you need to make sure parents understand they need to give it more than once, and they need to follow the taste with a desirable parent response. And that's not easy to do. So parents oftentimes mimic what the child does. You offer a flavor and the child gives you this, oh, face, and what does the typical parent do back? Oh. They say, oh, you don't like that? Well, he doesn't like it now. So some of these are just helping parents to understand children are looking to them for reassurance when things are new or different. So we do know that increased exposure to foods may generalize acceptance to new foods, and a variety of foods, giving children lots of experiences as opposed to a lot of exposure to just one food, appears to improve the acceptance of novel foods, at least within the food group. So there have been research studies that have given children a variety of fruits, and those children are more likely to eat even new fruits. Now, it doesn't yet seem that eating a variety of fruits helps you with eating a variety of other food groups. That has not been consistently found. The number of exposures, the number of opportunities of tasting when introducing a new pureed food appears to be more than 1 or 2, and most parents stop at 2. And most children are going to eat that new food after about 8 exposures. But exposures really are in the mouth. So how do you get from looking at a food to getting it in the mouth? That's what we're going to be talking about. So this face is not, oh, this is awful face. This is, oh, that was new face. And so it's really important when your child looks at you, when you offer the brand new food, that your response is, yes, I know, that's new. Or, I hate peas too. Right? When you're talking to a baby, it doesn't matter what you say, but your face has to be happy. The most important determinant of a child's liking for a particular food is how familiar it is. And yet one of the biggest mistakes parents make is when you offer a food and your child doesn't appear to like it, or they say no, why would you keep offering it? Most parents are not even giving their children the foods that they would like them to learn how to eat, because when they gave it to them, the child said no, and the parent doesn't know what to do next. So that's the practical strategies we're going to give you this afternoon. All right. Where am I on time? I have, or we have? Okay. Sorry. Okay, let me talk about developmental milestones that help children. We need to think about these things because the way that a child's gross motor skills, fine motor skills, oral motor skills, sensory and interactive abilities with their parents and how they think about the world all influence eating. We know that gross and fine motor skills directly influence the ability to eat. And there was a beautiful study out of Latin America that followed children for 24 months. They saw them for 10 time periods, and they were able to show gross motor development happens before oral motor skills come on board. And so we'll talk a little bit about this. We start with gross and fine motor skills. In the beginning, with babies, gross and fine motor skills are not as important because babies don't self-feed, babies don't have to sit up. And so the typically developing healthy baby may actually still have some gross and fine motor challenges that are influencing feeding. Over time, babies go from completely being held and having all of their support to their body being provided by the parent to sitting and sitting upright and then sitting upright and using their hands to self-feed. And so these are increasingly challenging steps for babies and young children. Fine motor skills start off with just reflexively grasping, but over that first 2 years, then become more refined into raking and then pincer grasp and, well, 3-point and pincer grasp to using utensils. And we'll talk a little bit about how we need to think about foods that help with those different stages. As the child ages, they have improved trunk and head control. They begin to have independent sitting. They have more awareness of their whole body. And a very important skill is bilateral hand play and crawling. So as a child starts to move into crawling, what you see is that they're building connections between the right side of their body and the left side of their body. And when it comes to eating solid foods, your tongue has to move side to side. So you have to have a coordination across the two parts of your body. Gross motor really influences postural stability. Out of stability comes mobility. That's the way therapists think. And so postural stability, being able to sit and be really stable when you're sitting, frees up your brain to think about all of the other things going on during eating, as opposed to, okay, I have to make sure I don't fall over. It helps with your respiratory function. It provides security. It allows for better hand-to-mouth coordination and manipulation of the food, and it helps with the range of motion in your jaw. So when you look at this little guy, this is a baby who doesn't have good trunk stability, and he's in a seat that is making him sit really upright. But do you see that he doesn't have the muscles to sit like this, so he is now like this. He is now scrunched down like this. Okay, so look at his mouth, how he's kind of like this, okay, because he is trying to make sure he doesn't fall over. If you look at his feet, he's like this. He's like, okay, I'm doing my best here, okay? So just by putting him in a reclined seat, because he doesn't have the support in his trunk yet, you see that we have more stability and mobility for his arms. His face is much more relaxed. So for spoon feeding, this would be a lot better. We see that children with low muscle tone really struggle with eating. The key is there are a lot of children who have kind of low normal muscle tone. So if you have very low muscle tone, like a child with trisomy 21, most of those children are recognized. But we know that even if you have kind of low normal muscle tone, and really it's all on a continuum, where is that continuum change? They may show us that eating is really difficult. They may slouch. They may prop, so they may have one arm on the table while they're trying to eat. They may lock in their joints. They may like to stand up and eat because it's easier. They're more stable when they stand and eat. Okay? So they may try to lock at the hips. They like to walk around and eat. So I'm going to have you do something very quickly here to help you think about this, okay? Think right now about how you're sitting in your chairs. Now I want you to actually sit up straight. And what do you end up doing? When you sit up straight, what did you just do? You had to engage your stomach muscles, didn't you? Right? You had to suck those in, and you put your feet on the floor, right? Nice and stable. Okay, you can relax. It's hard work, isn't it? Okay? So think about how you just adjusted yourself so that you could be more stable. This is a little girl who is sitting up all on her own, but when you look, she is fixing in her body so she doesn't tip over. So when you look at her first, it's like, oh, she looks like a typically developing little girl. But how many little girls, how many children, when they're sitting on the floor, sit with their arms back? Her arms are pulled behind her back. She's pulling here so that she can get very stiff so that she can stabilize herself. And then look here. See again? She's doing this. So when we're looking at why a child like this is not transitioning to picking up food and feeding herself, we are thinking, well, part of why she's not picking up food is you can't pick up your food when your hands are back here holding you up, okay? This is very common. This is a little guy who came into feeding clinic, wasn't eating, taking a bottle, but was not eating any solid foods. He was being sat in a high chair, and if you look underneath, his feet are grabbing onto the high chair so he doesn't fall over. Okay? So we just helped the parents change, put extra pillow around him so that he felt more stable. Okay? Or giving him something to put his feet on. So one simple thing that we talk to families about is that most of our children, we ask them to eat on chairs that are adult chairs. So adjust the adult chair. Put in extra supports. Put a pillow behind them so that their knees can come over the edge. Okay? Because what do a lot of kids do when they're in an adult chair? They pull their knees up and they put the knees between the table and themselves. They do that so that they have more stability. And then put something under their feet. That is a very effective strategy for families. So taking a box, filling it with sand, and taping it up and putting it underneath the child's feet so that the feet can be firm on a floor. Okay, so fine motor skills. We're going to talk about how the food can make it easier or more difficult for children to learn how to do this. The first thing that children need to do is be able to put things in their mouths. So toys in their mouth and fingers in their mouth. And a lot of families don't want anything in their mouth because they're worried their child will choke. So it's, again, trying to help parents understand that we have to first think about choking, but we also have to think about the tongue needs to be able to move with the hand and feel different textures on it before the child really is successful with different textures with food. So we work a lot with families on what is safe to put into the child's mouth. Even letting the child put a spoon in their mouth or you know, a doll, something like that, will help them. Okay? Then they start moving into swiping and trying to grab foods. They'll grab with the whole hand and then move towards more refined motor skills over time, and moving all the way up into finger feeding. That helps them to learn to eat with utensils. From an oral motor standpoint, the oral motor skills begin very simple. Breast and bottle feeding is open and close the mouth. There is vertical movement only. The tongue is not having to move side to side. It goes up and down only, and it's being driven by primitive motor reflexes. And those reflexes, those responses, go away sometime between 2 and 4 months of age. And around that time, between 2 and 4 months of age, the central pattern generator, which has been providing that kind of automatic sucking response, goes away. This is why some children go home out of the intensive care nursery eating and stop after they go home. It isn't that the parents did anything wrong. It's that the baby hasn't learned during that time that eating is fun for them. There's something that's interfering with that process. As the child then transitions to the next phase, we move into spoon feeding. Spoon feeding is a time when the baby is learning about taste. There's not a huge variety of texture for most of our smooth purees, but they also are learning visual interaction. They are learning to take turns with their parents. There's a lot of give and take and parent interaction that's happening there. The tongue is going to start to move the food back in the mouth. We know that from a study of full-term babies and preterm babies that these skills are being acquired generally on a adjusted age schedule. So that's another place that parents get mixed up. If you have a baby that was born 3 months early, their development is 3 months behind. That's the way we think. I always say it's not fair. They got kicked out early. But so when a parent thinks that they have a 6-month-old baby and they should be eating purees just fine, a preterm baby development may be 3 months, and a 3-month-old doesn't have the skill necessarily. So all of eating development is based on skill, not age. And this was a lovely study that came out that helped us to think about the skills are based more on adjusted age. So lateral jaw movements, lateral tongue movements. So the movements go from vertical to movement side to side in the tongue, movement side to side with the jaw and tongue, I should say first, and then The jaw can move one way and the tongue can move the other. And finally, we have the rotary movements that come on board. So you see from a skill standpoint, the basic movement patterns are there. There is a multi-year process to really refine these movements. And Dr. Green, who's done beautiful work around rotary chewing motions, looks at the development, the refinement across 3 to 4 to 5 years of age. Anatomically, babies are built to be breast and bottle feeding. And everything is compressed vertically because the movements are all vertical. They have little fat pads, and they have a structure in their aerodigestive tract that helps them to suck, swallow, and breathe. But around 5 months of age is when anatomically the jaw grows down and forward, there is additional space in the oral cavity, and then the epiglottis and the soft palate begin to separate. Babies are starting to get ready to be solid food feeders. From a sensory standpoint, in the beginning, it is as easy as it gets. So again, we have kind of a natural progression across developmental domains. So when you think about what a baby is looking at, smelling, tasting, the movement patterns in their mouth, when they're breastfeeding, it's exactly the same, except that the breast empties. And the flavor of breast milk changes based on what the mother is eating. So there's very small differences across breastfeeding, but many of the sensory inputs, the visual, the look of the parent, the sound in your head, the touch, the taste, the smell, all of those are really consistent feeding to feeding. Bottle feeding babies, if they're eating formula, they get this exact same sensory input every time. So think about experiences build brain pathways for new activities. So the bottle-fed baby is actually having less variety in their flavor palette from the very beginning. Pureed foods start to increase the challenge just a little bit. The visual inputs change from food to food. The color changes a little bit. We have kind of the yellow, orange, brown, and I don't know, green for the most part. Okay? The sound when you're eating a puree, there really isn't any sound. The touch on your mouth, the taste and the smell, there's some differences in the flavors. Balance. Now, if I'm not being held, I have to sit out here and keep my head stable. There's more requirement for that. And proprioception. Proprioception is the pressure between your joints. So your temporal mandibular joint is giving feedback to your body about what's happening. And so think about how much pressure you use when you're eating an overcooked steak compared to eating a soft croissant. And there are different feedbacks that go there. But the other thing about purees is that something parents do often is they give the exact same puree over and over and over again. So if they're going to give bananas and chicken to the baby, many, many times they will open the jar of chicken and say chicken, 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 chicken. And then the baby may go, enough for the chicken. And then they'll say, okay, banana, 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 banana. Okay? What we know, and you're going to get some research about this, is that changing every spoonful will actually help children learn more about foods. So banana chicken, banana chicken, banana chicken, banana chicken, something as simple as that can help a child to learn to be more open to new flavors. Textures. Textured food is as difficult as it gets. Okay? When you stop and think about all of the foods on the planet, they have different visual, they have different auditory, they have different taste, different smell, different feel in your mouth. They require different chewing pressures. So every single food is different. But that's not what makes them hard. What really makes them hard is that as you eat textured food, it changes in your mouth, okay? So think about eating a cracker, okay? Just a regular cracker. When you first take a bite, it maybe is really kind of salty. It may, when you take a bite, have one piece that fell into your mouth. But when you bite that piece inside your mouth, now you may have 3 pieces, or 5 pieces, or 7 pieces. So every time you chew, the number of pieces are changing. The feel of the pieces go from harder to softer as it mixes with your saliva. You have to keep track of all of those pieces, so you have to be bringing those pieces together into a bolus. The flavor changes from more salty to more bready. Do you see how eating textured food is actually very complicated? And let me tell you, the group of children where you will see this the most are the children on the autism spectrum. This is why the children only want to eat the one cracker from that one box. It has to be that cracker. And when the parent opens up the box, it has to be that square cracker. If a piece is missing, they won't eat it. Why? Because to them, they're so fixed on the sensory that it's to them, it's not the same food. So different children have different ways that they express the textured table foods is really challenging. The next stage in sensory development that we have to think about is we have children who eat food that is all by itself in little piles on the plate, not touching. Okay? But when you try to put those together, kids don't want to eat it, right? They have the pasta and the sauce, but they don't like to put the two together. Well, part of it is because as you put things together, it becomes more and more complex. So during this transition, across from liquid to puree to textured foods, children must learn to accept a variety of ever-changing sensory inputs and learn a variety of sophisticated oral motor and other skill-based movements. And food neophobia and food pickiness typically start to develop between the end of the first and second year. And the social context influences the willingness of the child to try new foods. So parents are going to be the influencing factors. So experiences are really important in this age range. A preference for sour tastes is correlated with increased fruit consumption at 18 months. Because if you stop and think about it, a lot of our fruits have both a sweet and then more of a sour flavor, like the skin on grapes. Is much more sour bitter. Taste exposure to novel foods is the most effective and long-lasting strategy for increasing acceptance of new foods. Flavor learning and post-ingestive flavor preferences may also be developing, and we're going to capitalize on all of these. And experiences matter. Liking for vegetables appears to be learned, and having a child take a small taste of a vegetable and allowing them to spit it back out increases their willingness to try new foods. It's amazing how many foods a child will taste if you just give them a permission. It's okay. If your body isn't ready for that, you can spit it into your napkin. We don't let them spit everywhere. So we need to teach them how to eat a variety of foods. Okay? Children are more accepting of new foods when introduced under the age of 1. And food refusal significantly increases after the age of 1, and by age 3, children often reject foods that were even previously accepted. Now they're like, oh no, haven't seen it for a while, I don't know what it is. Fruits and vegetables are less accepted over time, and once 2-year-old children taste a food, they accept a novel food with a similar number of taste trials as 3 to 5-year-olds. Children at 3 years of age do not have as stable of flavor preferences. As they get older, they become more and more rigid about what they will eat because they are thinking about the world differently. As they cognitively change into different ways of thinking about the world, they become more opinionated. So earlier introduction of vegetables and fruits is correlated with later eating fruits and vegetables. Food jags is another myth, is sort of how we talk about it. What are food jags? Food jags are when the child says, I want hot dogs, or I want, the same food over and over and over again. And parents give in, right? Parents are like, oh, all he wants to do is eat hot dogs. What's the problem with letting them do that? Because you are limiting their experience with other foods. And so at a minimum, what you're going to see is that while we may give the child the preferred food, it will be in addition to the other foods the family is eating. That's how we're going to be working with children. Because if we give it to them over and over again, just like you or I, they sometimes just say, ugh, I'm done with that food. And then we lose a food. That's what happens with kids on the autism spectrum. They've eaten the same food over and over again for years, and now they decide, I'm done, I don't want it anymore. But they haven't learned about new foods, so they go from 5 to 4 to 3 to 2 foods. From an emotional cognitive self-regulation standpoint, in the beginning, the babies have no idea that they have an opinion. They are trying to figure out their own bodies, and they don't have an understanding of self. Parents really are setting up opportunities for babies to learn about themselves. As babies start to mature, they learn that they're different than their parent. They learn to work in turn-taking activities like peekaboo. Spoon feeding is a turn-taking activity. They develop social smiles, and they're differentiating their cries. So when you look at this picture, this is the perfect example of reciprocity, of turn-taking. So the child is recognizing that the grandfather isn't getting the spoon close enough because the grandfather has some arthritis. So the child is saying, oh, I'll help you. And the child is leaning really far. This is the social interaction that happens when we are spoon feeding our children. With maturation, they move into understanding themselves differently. They start to learn to move away. As I move away from my parent, I'm more and more understanding that my parent is different than me. And if my parent is different than me, then that means I have my own personality. And how do they assert their personality? They take control. They start to say, I am going to say no. If I always say yes, how do I know that I'm different than you? So they start to want to do their own tennis shoes, and they want to pick out their own clothes. And food is a big area where they try to take control. So, Sarah, do you make it? I don't know what time it is, so make a decision on. We're good? Okay. All right, so I'm going to hand this over to Sarah, who's going to talk a little bit about the developmental panel and about how the development is working towards different food products.
Great.
Right.
Hello, I'm Sarah Smith-Simpson, and I'm a principal scientist with Nestle Nutrition in the U.S., and I've been working with Nestle, well, Gerber Baby Food, and now Nestle for 11 years. And I would have to say, every time I listen to Dr. Ross speak, I learn something new. So it's such a pleasure for me to be here with her as well. And I would say about 7 or 8 years ago, I took on a new role within Nestle. And it's really my job now to continue learning from these specialists like Dr. Ross and Dr. Toomey, who she works with, and trying to translate all of this knowledge that they have around children into products that can help parents and ultimately help healthcare professionals help in this feeding journey. So probably in the late 1990s, Nestle actually started a collaboration with a group of feeding experts. And these feeding experts include speech-language pathologists, similar to Dr. Ross, physical therapists, occupational therapists, actually even a child psychologist like Dr. Toomey. And we really wanted to create a broad-based model. How can we help parents learn everything that Dr. Ross has just talked to us about, and how can we make it easier for children to get through these transitions? So once we could internally understand all of these transitions, then how do we change our products? How do we make our product offerings better? How do we create more education? And how do we really have this partnership with parents to really create these healthy, independent eaters? So this is what we created. It was actually our internal feeding development model. But we can't translate this. I mean, we can't give this to parents and say, look, these are the skills your child should learn, and these are the products, these are the foods that you should be feeding your child. We needed to come up with a more easy, user-friendly way to talk about these strategies. So the biggest thing that this model said to me is, we worked with these experts and all of their experience and their knowledge that they had, and what we did is what we realized, just what Dr. Ross said, age matters, but children develop these feeding skills at a different age, right? So they all go along the same continuum, but they do it at a different rate. So we decided to create stages within baby food. So Gerber and Nestle were the first ones to do this. And so we have stage 1 foods rather than talking about kids at 4 months of age or 6 months of age. We talk about stage 1 foods. And we don't talk about an age always that a child is ready for this. We talk about the skills that they have, right? All the different oral motor skills, the fine motor skills, and actually the environmental skills that Dr. Ross outlined so beautifully for us. That's how we speak to consumers. So on the back of these packages, it will say your child may be ready for this product if they're sitting with help and support. On their tummy, they can push up on their legs, and they're starting to gain head and neck control. So we want parents looking at the gross motor skills, the fine motor skills, and the oral motor skills that their child has as they transition through these different products. So our stage 1 foods are very thin purees and thin cereal. And we like to talk about these as a semi-liquid texture that flows right off the spoon. Something that's easy for a child to move in their mouth when they only have that forward and back tongue movement. And then stage 2 foods, these are going to start to get thicker and coarser. So this is when kids start to use like a tongue waving pattern. They can move things in their mouth much more efficiently, and they're able to, like Dr. Ross mentioned, experience more texture and more flavor in stage 2. Stage 3 is a huge stage. This is when kids really start that side-to-side tongue movement. I always love to talk to parents about how when a child starts to crawl and they can correlate their right hand with their left leg and their left hand with their right leg. Dr. Ross mentioned they're making these cross-body connections, and thus they can move their tongue side to side. That's when we can start introducing texture. That's when we can start introducing some of the small finger feeding products as well. So it's really about correlating the skills that the child is developing with the right textures at the right time in a baby food system. Fine motor is so very important. And so in a few minutes, I'm going to walk you through a product that we actually have on the market that I'm so excited has come to Mexico now. It's called Gerber Puffs. And it really was designed by our feeding development panel because they said we need to create the perfect first finger food. So you're going to see that a little bit later. So baby food pouches. So do a lot of kids come into maybe your clinics with these pouches, these flexible baby food pouches? They're becoming very, very, very popular. And so what we learn is that kids are able to eat pureed foods out of these baby food pouches much sooner than they can actually spoon feed themselves. It offers them a good venue, but we have to be careful with this because there's not as much experience. There's not that reciprocity that Dr. Ross spoke about when we get into these baby food pouches. Stage 4 are the junior foods. This is really when Dr. Ross started talking about texture. But, you know, like she said, when kids turn 12 months of age or they start walking, we start thinking about these toddlers. They're not ready for meat. They're not ready for raw vegetables. I think a lot of pediatricians that I work with across the globe say, by 1 year of age, your child should be eating the exact foods that you are eating in the home, right? Get them transitioned to table food. But in reality, all those skills that Dr. Ross talked about needing, they're not usually there at 12 months of age. So we really have to think about soft biteable foods, meltable chewable foods, and different soft chewables, things that help kids transition into those more advanced textures. And again, thick spoonable foods. When kids actually start, you know, learning how to eat with utensils on their own, it's a really challenging proposition. If you think about all the different joints that you need to engage to actually successfully spoon feed, right? So you need to coordinate your wrist, your elbow, and your shoulder, shoulder joint, just to scoop the food, then somehow get that spoon into your mouth, and then coordinate your lips to actually remove the food off the spoon, and then start all over again. So it's a very complex thing, and we can change the textures of our products and make them thick and make them spoon hugging to actually help coordinate this for children and lead them to success. Because if they fail and they make a mess, or if they work really hard and they're not actually able to eat any food, we learned that kids are going to learn that was failure. That was not a good experience for me, and they're not going to want to continue, correct? So we really want to work all the way through the first 2 years of life, and maybe even later than that, to provide kids with the right textures at the right time. So one of the ways we've done that as a company, Nestle, we've committed to new product development, and I'm going to give you some examples of how we've taken all of this wonderful knowledge from Dr. Ross and some of her colleagues and actually applied it to our portfolios. Coming to events like this to actually hopefully provide some new information and provide some education not only to healthcare professionals but also to parents, and then really doing a lot of child supportive research. There's a lot of new trends happening, I think, with these millennial parents. Some of you may also be millennials, and Gen Z is coming very soon, we're learning, and they think differently than some of our other parents. So these next generations think very differently. So how many of you have heard of baby-led weaning? Okay, I see a lot of people nodding their head. So baby-led weaning is really a kind of grassroots sort of feeding approach that started in the UK many years ago. And they basically say, just skip baby food. You don't have to give your baby baby food. They say as soon as your child has the skill to pick up that pork chop or to pick up that raw carrot and get it into their mouth, they're ready to eat it. So, okay, not true. And Dr. Ross has done quite a bit of research in this area of baby-led weaning if you want to know more. But we actually will partner as well with some of these experts to do research and to find out there are some pros to baby-led weaning. Children are exposed to a wider range of textures and flavors, but we also know that there are some cons, there are some negatives, safety being one of them. There have been incidences of children choking with baby-led weaning, as well as are they actually getting the nutrition they need? So if they're eating a raw carrot, they're getting that texture exposure, they might be a great teether for them, but are they actually consuming the nutrients they need, and are those nutrients digestible? So these are all the things that we learn as we partner with these expert panels. So I have 4 examples of how Nestle I would say within the last 10 years, we've really worked on taking the knowledge from our expert panel and applying it to our products. So the first one, I'd like to talk about a product that we call Just a Taste. So you heard Dr. Ross talk about multiple exposures. But when you look at the baby food aisle, that stage 1 exposure, it's usually 3 to 4 ounces worth of product. And if the child does one of those, like Dr. Ross talked about, or they spit the food out or they reject it, most parents dispose of that product and they don't try it again. Dr. Ross talked to us about 2 exposures is about the average for a parent. So what we did is we actually created a First Foods kit. So what we did is we actually took little small tubs and we made combinations. So there's 3 little apple tubs, 2 pear tubs, and 3 banana tubs. So this gives parents an extra opportunity for multiple exposures. So they open one, the child can try it. If the child refuses it, there's another one to try the next day, or the next, or the next. And we also included with that a little information brochure. And it actually has a little grid on there where you can write down when you first exposed your child and what their reaction was. You can actually kind of take a little diary of like what the child reacted to. And we also give a lot of that information to the parent. Okay, so they make a funny face. That might mean, ooh, that's new, not, ew, I don't like that, or I will be willing to try again. So this was a direct application of a lot of that information that Dr. Ross talked to us about in trying to bring this new product to consumers. So we talked about that third food, that stage 3 stage being very difficult, because this is really when kids start to get texture for the very first time. So over the years, of course, products have changed, and a lot of times stage 3 products, some of them would have texture, some of them didn't, some would be thin, some would be thick. So we really committed ourselves to revamp our entire line of products. Now when we started off doing this, we asked consumers, are you buying stage 3 products? And what they told us is, no, we're not buying them because they're no different from stage 2. So we were not meeting what consumers wanted. So we were offering them this big jar, and they were saying, well, you're talking to me about stage 3, but it's just it's just more food. I can just open up multiple packages of stage 2, and this really was not preferred packaging. It was not complex in flavor or texture. So we really took this to heart and started doing some more research. The next thing we realized was we couldn't just increase the texture. We couldn't just maybe take some soft apple dices and throw them in applesauce, because the very first time we tried this, we had some very negative reactions. So this is a little boy named Joel, and he's on our feeding panel in Michigan. So he's trying one of our prototypes for the first time. So in this prototype, it's advanced texture, let me tell you. So there was some thin applesauce with some pretty hard pieces of apple dice in it. So now, for those of you, that is a classic gag reflex, right? So when we really looked closely at this video, we found that Joel was swallowing the sauce right away, and it was leaving him with these really hard apple dices in his mouth. And he had very little tongue lateralization. So those apple dices were, and then he's hiding. He's saying, no more. He's really rejecting. So he's trying, but look, he's just so unhappy. So this is exactly what we wanted to avoid. So when I work with our product developers, and I tell them, and they'll come to me with a prototype, and they'll say, well, this one meets my cost right? My cost restrictions. I can make this product. And then I would say, remember Joel? Remember Joel, and remember his face, and remember how ultimately in this one feeding instance, he's just outright said, Mom, I'm not eating anymore. So that gag reflex, he didn't have the skills to feed this product. So he matched a stage 3 baby, but he didn't have the skills. So we really took it upon ourselves that it was really, really important to get the design of this stage 3 product right. So what we did is we kept developing and developing and developing, and we kept testing with kids to make sure we had the right texture. So we ended up recruiting over 150 children, ages 8 to 15 months, and we actually ended up testing different concentrations. So how many dices should there be? How many little pieces of actual food, and how much sauce should there be? How thick should the sauce be? How thick to actually suspend those particles so a child could move it in their mouth all as one and the particles wouldn't separate out. So we videotaped every time the child ate this, and we actually counted the number of times their jaw went up and down. Because what I've learned, one of the very first things I learned from our developmental experts is a child will only work as hard to eat a product as they have to. If they can swallow something whole, they will swallow it whole. If they don't need to chew something, they will not chew something. But we really wanted this line of products to be early chewing practice for kids. So we wanted that to be the perfect design. So we watched over 200 hours worth of video, counting every time the child mashed or chewed the food, and actually timing how long each spoonful stayed in their mouth. And I think we had great results. So what we really did is we compared our old design, which had no particles, no dices in it, with our new design. And so what you can see is the green bars were our old products, and the x-axis there is the number of mashes. So you can see it goes from 1 mash all the way up to 9 mashes. And the solid green bars are actually, that's our old product. That was just like a stage 2, just in a bigger jar. And the other multicolored columns are actually our new products, where we added a thick sauce and the dices. So you can see we actually moved, and on average with our fruit and vegetable products, we went from about 3 mashes per spoonful up over 5 mashes. And the time in the mouth, we were able to change that as well. Kids were usually spending about 2 to 3 seconds with each spoonful, but with our new design, they were actually spending over 6 minutes overall on average. So this is Gianna. She's one of our little taste testers. Oh, and hopefully you're going to see her eat both the old and the new product, and hopefully you'll see a significant difference between the two. So, she likes it okay. She's eating it fairly quickly, right? She's just kind of moving that product from the front to the back of her mouth and swallowing it. So that was just a straight squash, a squash puree. So now we wanted to introduce her to something more complex. So this is squash, corn, and carrots with little sweet potato pieces in it. So hopefully you'll notice all that mashing and chewing that's happening.
Great.
She seems to like it a little bit better too. A little bit more enthusiastic about that complex texture and complex flavor. So to us, that was a huge win. So this went on to become quite a big science-led campaign in the US. These products were launched about 2 years ago, and the whole campaign was around Chew University, or Chew U. So we really promoted this to parents as your children are coming to Chew University to learn how to chew. And we're trying to provide you with all of these products. So what was really interesting is when we came with a lot of these claims about these products helping your child practice chewing and learn how to chew, all of our major television producers, TV and ad campaigns, we had to show them the actual data. They wanted to see that raw data around a lot of the claims we were making. So this was a very successful campaign for us, and we now have 20 different fruit and vegetable products on the market now in the US. So that was a huge success that came straight from our developmental experts. Okay, I gave you a little teaser that I was going to talk about puffs, and this is probably one of my favorites. I would say about 15 years ago, one member of the panel came to Gerber and said, we need to take on Cheerios. Now, are all of you familiar with Cheerios, which are an adult breakfast cereal? They're like an all-family cereal. Well, they started campaigning, they started advertising that they were the perfect finger food for toddlers, for babies. They were the perfect first finger food. But if any of you have ever eaten them, and most of the time when I present with Dr. Ross, she comes with samples. So maybe next time we can coordinate the samples. But if you actually eat a Cheerio, now in the world of food science, which is my background, you think about, when you talk about all family cereals, you talk about bowl life. Bowl life. And so in that, you want your cereal to stay crunchy and crisp when you add milk. So Cheerios were designed to stay crispy in milk. Well, that's the exact opposite of what little kids want. For little kids, we want something that softens very quickly and dissolves very quickly. And so again, with Cheerios, when kids start mashing it, it's going to break into multiple pieces, like Dr. Ross talked about. And now you're not only managing one piece in your mouth, you're managing multiple pieces in your mouth. So we set out to take on the Cheerios and to come up with a good finger food. So I want to show you a series of videos that we really took a lot of time and effort with this perfect first finger food to look at fine motor skills as well as oral motor skills. So you're going to see 4 different examples of children eating puffs. So this is Reagan, and she's 8 months old. So you notice she just kind of raked all those puffs up. So what we did is we sprayed the puff with a little bit of fruit juice. So you can notice they stick to her fingers and they don't fall off. So they actually stick to her gooey, slimy, kind of slobbery hands. But that was on purpose. We wanted them to stick to her hands to help with self-feeding. Now this is Jeremy, and he actually has much better, kind of that 3-finger grip, or he's starting to go for that inferior pincer grip. So you'll notice he's picking one up at a time. We'll do that. I guess my computer's being very sensitive today. So puffs were not only great for Reagan, who's raking and just first learning, but also for Jeremy, who's actually able to pick one up at a time. Now, when we think about from an oral motor standpoint, that tongue lateralization, or moving the tongue side to side, was very important. But we wanted to design this product for both kids who had tongue lateralization and those who didn't. So this is Liam, And Liam hasn't quite figured out how to move his tongue side to side. But when he's eating the puff, he uses his fingers to actually hold that puff in there while he softens it and then ultimately moves it over to the side of his mouth with his fingers so he can mash it a little bit before swallowing. And thus he had a really good experience. And then we have our little Lucy. She's our rock star. And she has wonderful tongue lateralization. You can see her tongue flip right over there to the side. And her tongue actually plants, right? It like holds that puff there on the side of her mouth so that she can mash it. And so again, she's practicing her tongue movement, her tongue lateralization, and loving it at the same time. So that was really for us, really a slam dunk. And this has become such an incredible product on the market, and I'm so excited to say that it's expanding into many different countries. So right now, we're actually installing a new line into the factory in Querétaro, so we can make those here locally for the Mexican market. So that's very exciting for Gerber. And so I think the last little story I'd like to tell you is about those baby food pouches. So are most of you familiar with these flexible pouches? They seem to be kind of everywhere, even upwards through school-age kids, right? They're perfect for the lunchbox. But when these first came on the market, I would have to say, Gerber, we were not the first company to bring puffs to the market. And that's because we believe so strongly in spoon feeding. And what we were seeing was a lot of criticism actually coming out of the healthcare, out of healthcare professionals, dietitians in particular, around the fact that kids eating directly out of these baby food pouches, they weren't getting all that experience they get from spoon feeding. So we took a little step back and we thought about, well, how can we kind of approach this? And so we started doing some research, and we really wanted to bring some good news to these baby food pouches. If we had to get behind this. We had to almost convince ourselves that we should have this type of package on the market. So one of those reasons was vegetable consumption. So internally within Gerber, we talk about vegetables being the holy grail. So I'm not sure if that's a term that's familiar here, but vegetables are absolutely so difficult to get children to consume. And so you can see these trends. Gerber has run the Feeding Infants and Toddlers study. It started in 2002 and then was refielded in 2008 and then again just last year. And it actually looks at upwards of 5,000 children between the ages of 0 and 5 years old, and it does a 24-hour dietary recall. So we get a really good snapshot of what kids are eating, and they're not eating vegetables. So you can see vegetable consumption, the percent of kids consuming any vegetable during the day. You can see we do a pretty good job, and it's increasing between 4 and 9 months of age. But it's either holding steady over the last 14 years or declining. When kids get 18 months of age and above, we're actually seeing a decline in the number of kids who are actually consuming any vegetables in a given day. So we need to do something, right? This is a trend. Dr. Ross talked about the fact that kids eat junk food all the time and they're not eating vegetables. So we did a little bit of studying. We thought, well, these baby food pouches, kids can't actually see what's inside the pouch. So could this be an avenue to try to expose kids to vegetable flavor? Because one, they can't see it, and two, they love eating out of these pouches. It's a very novel, it's a new way, and it's very independent. Around 1 year of age, they want to do everything by themselves, right? And these pouches offer them the chance to do that. So we had two hypotheses that because the kids couldn't see the green color, which are the hardest ones to feed, the bitter cruciferous greens, and because a pouch is a lot of fun, more kids would be willing to at least try the foods. Maybe they wouldn't eat more, but at least they would have that exposure. So you can see the two products we picked. These were two of our competitors that had products on the market at the time. And one of them is spinach, apples, and rutabaga. And the other was a mixed green and pear. But you can see they're really, really, really green. So what we did is we brought kids in, and they were kids aged 24 to 36 months, and they either saw the pouch, they tried products out of the pouch, or they got that product in a bowl with a spoon, okay? So what we found was we were able to support our hypotheses. So 60% of those kids were willing to try the product when it was in a pouch versus 29% when it was in a bowl. So we almost doubled the amount of kids that would actually just try the product. And 80% of the parents said the reason they rejected the product in the bowl was because the color. Kids were looking at it and rejecting it outright. So our first hypothesis around base of the color was successful. And then number two, we did see a lot of novelty with these pouches. So we were able to double the number of kids actually willing to try these in a pouch because one, again, parents said they couldn't see it. Number two, they say they like the package, it's a lot of fun, and it's novel. Kids showed a lot of enthusiasm for trying something out of the pouch. And did I mention all of these kids were perceived by their parents as being picky eaters? So that was like the worst case scenario, is these were all picky eaters. So this really tells us where the pouch has a place, possibly with these toddlers, you know, really with vegetable consumption. So I really want to wrap up my portion of the talk today, really talking about the fact that what we're really trying to do is partner with these feeding experts that we have in the US and actually globally. And we're really trying to reach consumers a lot through social media. So what we've realized is nobody's really wanting to go to Gerber.com anymore. Nobody wants to go to a website. And most of these parents, we have about 10 seconds to catch their attention. So we're really using that through social media. We're trying to connect with them one-on-one through workshops. We're actually partnering with Toys R Us and Babies R Us to actually talk to moms about feeding education when they come in to register, when they're still pregnant, or when they're coming in to buy products for their kids. And then we're also trying to do a lot more through webinars and through really small little educational videos on YouTube and, you know, different Pinterest and different things like that. So at this point, I was going to hand it back over to Dr. Ross, and I think we'll have to find out if we're going to have our break now. Okay, so we're going to have a little break. Hopefully we can get some coffee and we can get caffeinated again and get up and stretch. And then Dr. Ross is going to come back and actually talk to us a lot about these strategies that she likes to help parents with as well. So thank you.
We should have time for questions, and so that always makes me happy. I apologize. I'm not used to standing behind a podium. I walk and talk. And so I'm getting used to being up here, behind here, and stuck. So now we're going to start talking about what do we do when children aren't eating enough. And I know that you are all gastroenterologists, and so you will have many, many children who have learned that eating isn't comfortable and eating doesn't work for them. And so we have to figure out how do we help them to go back to thinking that eating is fun. But I also want to tell you that many of your children will have maybe problems with development of oral motor or sensory, and so finding a therapist like myself, there are people like me here. Actually in Mexico City, we did a training in Mexico City several years ago that can work with children if these kinds of strategies are not working well enough. So we're going to talk about strategies that will help parents when their child is not eating enough, when their child is eating too much, but of the kinds of foods that are not really nutritious, or when they're not really eating age-appropriate foods. So the first thing when a child isn't eating is to test hypotheses, to try and figure out why are they not eating. And I would encourage you to think about all of the areas and not the parents first, okay? And we're going to talk about why do parents do things that make it much harder. But the reality is, even parents who are not that perfect parent have children who eat just fine, right? We have a lot of children who you put the food in front of them, they just eat. And so when a child isn't eating, we need to first start with, are there any things that are causing the child pain? Or did they have pain? So I was just talking to two gastroenterologists who were saying that they have children who have had nasogastric feedings because they had, different GI conditions like gastroesophageal atresia or food allergy or something, okay? And I've worked with gastroesophageal atresia, tracheoesophageal fistula, and what I was saying is if they come to you, let's talk about reflux, because that's a biggie. If they come to you and you say, oh, this child has reflux, you may be able to fix the reflux, but you have to remember that child has been eating that whole time and been in pain. And so many children, babies, eat 8 to 11 times a day. If they come to you at 6 months old, that's many, many hundreds of times that when they ate, they were in pain. Ate, pain. Eating causes pain. So even though eating doesn't cause pain anymore, pain is why they were not eating. Pain is why they're not eating now. And so that's one thing. Pain is the #1 reason why children stop eating. And that is the same if they have food allergies or food sensitivities, where eating makes them feel sick. They don't know that it is one food that they have a food allergy. They're not smart enough to know that. They just know that sometimes when they eat, they feel sick. So they start to try and make it better for themselves, and they start to not want to eat at all. So that's one thing. Pain or discomfort, malaise, being just very, very tired. Your children who have had cardiac problems, cardiac and respiratory, those children work very hard to eat, and it is exhausting. And the parents are pushing them to get in enough volume. And so even after their cardiac surgery, sometimes they have just learned that eating doesn't work. So we know that eating problems are associated with over 200 medical conditions based on a very simple study. What we know, as I said, is that reflux is actually #1 in the history of children who have long-term feeding problems. This is a study of about 350 children in a feeding clinic. So their feeding problems have become so bad that they now need a multidisciplinary approach to try and make things better. And you see reflux is #1. But if you look, you could add gastroesophageal reflux disease, food allergy or intolerance, constipation, diarrhea, delayed emptying. When you start to add all of those conditions that you have to work with every day, GI is a massive problem in terms of why children don't eat. That's why I was so excited when I was told that I could come and talk to you because you will be the people seeing the kids that I see in feeding clinic. We just went over that children with immature motor systems, oral motor, swallowing skills, those skill deficits make feeding harder for us as parents, and it is challenging for our children. And what's difficult to remember is that if you think about developmental milestones, walking, just take walking. We know that the normal development of walking is somewhere between 10 months and maybe 15 months. That's a 5-month window. But when it comes to eating, we forget that, and we think, oh, all 12-month-olds should be eating this, and all 8-month-olds should be eating this. And that's why Sarah was telling you, we're trying to get parents to think about the skill their child has, not just the age. Skill deficit of sensory processing problems, children who have very heightened taste responses, as an example, or the touch of food really can be challenging. So one thing that I don't think is in the general treatment strategies that we're going to be talking about, but will be very helpful for you. If you have a baby or a child who was eating and has to stop eating, at least eating a volume, so they are put on a continuous drip feeding. Many times when we put a baby on a continuous drip feeding or a nasal jejunum feeding or a GJ tube, many times people stop oral feeding because the stomach can't handle the volume. And I work with GI physicians all the time in Colorado. What we're trying to get parents to understand is children don't need volume to learn skill. Children can learn sensory and oral motor with one little taste of flavors. So give the parents very strict guidelines about no more than this much, so no more than 1 teaspoon or 1 tablespoon, but maybe 1/4 teaspoon of 4 different flavors, or 1 bite or 1 forkful of a flavor. So it's really trying to think about, we can't give any volume to the stomach, but the more often the child has flavor and texture and practice with food, that is going to help when they are allowed to start eating for them to eat. That is the #1 thing that we try to do. Nutritional difficulties, so access to food and how the body utilizes the food, that's what you are experts in, certainly the utilization. The environment we are going to talk about. How do we help parents who've gotten into strategies that are not helpful? How do we help them change how they work with their children? And then how do we change the learning that the child has? So those are really the ones that we're going to be focusing on more. Recognize that many times a child who has feeding problems will come to you for the feeding problem. And as people like me work with them, we will find out that they have developmental problems. Many times feeding is the first skill to fall apart because it's so complex. And so, for instance, with children with the autism spectrum disorder, many, many months before they were diagnosed with autism, they were having feeding problems. That was the first problem that they showed. And you see that the mean age of referral for a diagnosis was 2.5 years, and they were about 3.5 years before they were diagnosed firmly with autism spectrum disorder. But across the board, they had later introduction of solids. They rejected them. They were described as slow feeders. From 15 to 54 months of age, parents were saying they are very difficult to feed. They continued to have that as a report. They're very choosy. That is a very classic description for the way that they eat. They had a significantly less varied diet that became increasingly more different because they were dropping out previously eaten foods. They were more likely to be eating a completely different diet. To us, that's a big red flag. Many children have preferences, but they are still eating some of what their parent is making. So the key here is to kind of recognize that when a parent says he's not eating, even if he's overweight, asking these kinds of questions is, what do you mean by that? He's eating enough food. Does he eat vegetables? Usually you will get no. Vegetables, fruits, and meats are the ones that I generally am asking about. So the challenge that faces all of us is how do we find those children who have feeding problems or growth problems who would benefit from kind of more in-depth intervention and investigation without creating anxiety in parents, because parents are very worried about their children already, and all of us have limited resources. So what I'm going to be really focusing on is giving you practical strategies to start with that will probably help 80 to 90% of the parents. It may not be enough, especially for children with gastrostomy tubes or nasogastric tubes. They probably have skill deficits that are going to need to be addressed. So we would teach all of our families the strategies we're going to share now, but we would also be seeing them in therapy. So one of the things that we know is that children, not all children are alike. And this has been one of the problems that has made it harder for all of us, because we all think that if you just give them the food over and over again, kids will learn how to eat. There was a very nice study of children from the United Kingdom, France, and Denmark. They wanted children from slightly different ethnicities or social backgrounds, but that if you've been to those three countries, it's not quite the same as some places, well, probably even in the US, that's a whole nother story. 40% of these children, so let me tell you what they did, sorry. They asked the parents to be giving the children new foods, different pureed foods, and they basically asked the parent to give it to them at least 10 times and record when the child was starting to willingly accept these foods. 40% of them were called learners. So these children increase the amount of food with increased exposures. So those are your kind of typically developing children where all you have to do is keep presenting it and they start to eat more and more. 20% were what are called plate cleaners. So right from the very beginning, they were adventurous and they pretty much would eat as much as the parent would give them right from the very beginning. So those children, even if you don't have really good strategies as a parent, you have a child that is kind of easy, hey? We all wish we could have those kind of children. 16% were what are called non-eaters. So 16% of the children, even when the parent was giving them 10 exposures of these different foods, they just never really started to increase the volume. Think about, that's hard for a parent. If you tell the parent, just keep giving it to them, and they're not taking any more from the first time that they were given the food to the 5th time to the 10th time. That strategy, while it works for many people, is not enough for many families. For 16% of the families, we're going to have to teach parents more than just keep giving it to them. And then 23% had all different kinds of variable behaviors. They couldn't really classify them. So the plate cleaners enjoyed the food more than the non-eaters, and the non-eaters scored highest on a food fussiness scale. So we need to be thinking about how does this affect parents, and how does this affect the parents' ability to teach their children. We know, and Sarah mentioned this, it's one of my favorite things to say, children will do the least amount of work to get the job done. Okay? They will cheat if they can. And because from their perspective, you know, they're just trying to meet basic needs. So children eat foods that work for their body. They eat foods that feel good, that taste good, that they can manage oral motor wise, that meet their hunger needs quickly, especially if eating is hard work. And that means that children gravitate towards junk food. I mean, if you stop and think about your favorite junk food, does it take a lot to chew? Right? Most of our junk food is very meltable. Our potato chips, our French fries, our candy, high calorie, low effort. And so if you don't have good strength, if you only can mash food up into your mouth, you're going to gravitate towards easy to eat foods, and especially high calorie. When you think about fruits, vegetables, and meats, I don't know about you, but in the US, sometimes we get these huge salads when you go out to eat. And there are times when I stop eating because my mouth is tired. Okay? Because it takes a lot of work to chew all of those vegetables. So when you think about food, the way children think about food, then you can start thinking, what are the foods the child eats? What are the foods that the child doesn't eat? Because children avoid situations and foods that don't work for them. So one of the things we have parents do in our clinic is we have them write a list of what are the foods your child eats, what are the foods your child rejects. And we actually just look at what's the same and what's different. And most of the time, I always say the children who see me eat what we call the bland and tan diet. So the crackers, the cookies, the potato chips, everything is tan, melts in your mouth, and they avoid hard to chew foods. So that's how I think about foods. I don't think, oh, he's not eating vegetables. I'm thinking oral motor skills, sensory skills, gross and fine motor skills for eating different foods. So the other reasons are poor postural stability. The child is in a chair that is making things harder for them. We often adjust how the chair fits the child. And then negative learning around eating. So in fact, when you stop and think about eating and the eating experience, we have two players. We have parents who come with their own skills and abilities. They have their own innate characteristics, and they have their own resources. So skills and abilities, their own likes and dislikes. Because we know parents rarely give their children food they don't like. That's a problem. We tell parents right up front that your child needs you to eat the food for them to eat the food. And so even if it's just once a day, we're going to start having parents be cooking the foods for both them and their child instead of just their child. So that's one thing we're going to talk about. Parenting strategies. What do they do when the child says no? I'm going to give you lots of them. Their ability to role model and to be there for their child. Some parents are very good when their child is getting upset at helping their child calm down. Other parents, when the child is getting upset, the parent is getting upset. And so we need to just know that this is a skill that some of us are not born with as a parent. We need to learn how to help our children calm down. Able to structure and manage the meal times. I'm going to give you lots of strategies for that because most parents don't know how to do that. And then teach them about child development and nutrition because parents don't know that either. They're not just born with that. Innate characteristics, their temperament and their beliefs. Some of us are really laid back people. I, most of the time, am. And so it takes a lot to get me kind of flustered. Thankfully, because I have children who have tried to get me flustered. Not on purpose, but I have had some challenges with my own children. There are parents who are very rigid. And so when you think about the child's temperament and the parent's temperament, sometimes they go together very well, and sometimes they're mismatch. And so we'll talk a little bit about that. That's something that parents are just born with. And then their resources. I always say, how much time does the family have? We ask our families in therapy to spend time sitting with their child, eating with their child, not eating in the car and running here and there. Having someone, it could be the nanny, but time is my biggest problem because parents are busy. And so I have to work very hard to find a schedule that will work for them. Their food availability and their financial resources, how much physical ability do they have for that? The child's abilities, we've talked about the skills and abilities already. We've talked about, we're going to talk about age and temperament and some taste differences, and then the experiential learning. How familiar is the flavor? What kind of feedback are they getting? When they try the food, is it good? Good for them is they don't choke, they don't gag, and they don't think it's too big of a flavor. So food is going to be positive or negative, and we want to make sure that we make it as positive as possible. The social context that they're learning, and then are they getting reinforcement? Either of positive behaviors or inadvertently of behaviors of escape. So this is a typical kind of thinking that nutrition has historically had. You have a parent, they just offer the food lots and lots of times, and then the child will learn to accept. And what we know is that actually there's something that gets in the way of the child learning about food. And what gets in the way is that the child has a reaction to the food that then modifies the parent behaviors. So parents start to do things that get in the way. They start to, quote, give in. They start to avoid eating with their child. They stop doing kind of these general treatment strategies because it's hard as a parent to watch your child suffer. It's hard to be working with a child. Think about your children who have gastrostomy tubes and how for those children, many times eating is difficult. It is a skill that they have to learn. And the parent, it's just so much easier to give them a bottle than it is to watch them struggle to learn new things. And so we need to recognize that when the child is giving reactions to the parent that this is hard, we have to give parents strategies that work to help the child move away from no and into yes. So to do that, we have to teach parents what to do. If their child has these reactions of rejection, we need to teach parents, so what do you do now? And that's where we're going next. So the parent influences are very, very strong. Food variety in the first 2 years strongly influences dietary variety in school-aged children. So in the first 2 years, we need parents to maximize exposure, even tiny little amounts. And that, I would say, unless medically contraindicated, that includes your children with gastrostomy or nasal gastric tubes. Taste and practice will be what's most important. Volume is not usually the biggest problem. When you start to teach a child to go from a nasogastric to a oral feeding, usually it's taste and texture that they're rejecting. And so really thinking about these first 2 years are critical. Children's food preferences are strongly related to mothers' food preferences. And so helping parents understand if they want their child to eat, An adult with a relationship to the child needs to eat the same foods as the child. Parents report that they offer a non-preferred food only 2 or 3 times before they give up. And even by 8 years of age, children still prefer foods that their mother prefers. So it really is teaching strategies. It's not just thinking parenting style will help this child. So in this study, what they did is they had parents with 2 children. One had a feeding problem, and one was a typically developing healthy eater. And what they asked was, okay, how do you feed your 2 children? And the parents said they use different strategies, which makes sense. For the healthy eater, they were less restrictive. They were, calmer, and because the child was eating with just kind of normal parenting activities. Parents reported using greater restrictive feeding practices with children who were fussier and desired to drink more than their siblings. So they're trying to restrict what the child is allowed to eat, which I'm going to share with you often backfires. And they use more pressure to eat with siblings who are slower to eat, were fussier, emotionally underate, enjoyed food less, were less responsive to food, and were more responsive to internal satiety cues. So when we think about these anti-strategies that I just mentioned, what happens is as the child's skills, abilities are not there, the reaction of the parent is actually creating what I call anti-strategies. These are not helpful. Pressuring to eat, restricting, those kinds of things. So restriction and pressure to eat are part of a non-shared environment. Same parents, same environment, different children, different strategies. Parents are doing the best that they can, but these strategies are not helpful. And so what we're going to talk about is how do we teach parents what I call situationally effective strategies. So when your child does this, this is what we can do. How are we going to help them learn that? How do we help them overcome no? So we know that learning occurs through repeated exposures, associations with past consumption consequences, so when I last tried it, it was good, and social consequences. Parents need to understand that the initial rejection is common. That is common across children with feeding problems and children who are typically developing. And the children are teachable. Parents think that the child just doesn't like that, right? Oh, my child doesn't like broccoli. And this is one of the concerns I have as a developmental specialist with the pouches. Because the pouches are great at getting taste exposure. But parents need to be still trying the actual food. Because children are learning to suck broccoli out of a pouch, and they have no understanding that that pouch is related to this broccoli. And what people say is, well, but it will taste the same. Well, it has to be in their mouth before that child knows that it's the same food. So I think pouches have a good opportunity to increase taste exposure, but parents think that magically the child will know how to eat the actual vegetable, and that's my concern, is that children need to be taught these skills. Parents need to focus on repeated exposures and not just liking. It doesn't really matter if your child likes the food, it's that they tried the food, right? And so shifting them into trying it more often will increase liking. The first time I ate an oyster, I did not like it. I ate an oyster, a raw oyster, because of peer pressure. And I did that a couple of times, and pretty soon I'm like, oh, I'm kind of liking this. And I was in my 40s. So you can learn even when you're not a child. Parents need these practical strategies, and strategies need to consider the child's reaction, not just the parent's reaction. So how are we going to help them? The first is something we call steps to eating. Parents think, well, I put it down in front of them, they should, taste it, and when the child says no, they don't know what to do. How do I get them to get it in their mouth? And they move into pressuring. You have to take a bite. I remember being told that I had to sit at the table until I ate my peas. Now, that was by a babysitter, and by the way, I like peas. I liked peas then, but I was 6 years old. So I decided I'm not going to eat my peas. And guess who won? Me. Because I sat there for hours. And I was perfectly happy because for whatever reason, I just decided I don't like being told what to do. And that's what kids do sometimes. So when a parent says you have to sit here until you eat it, a lot of times that doesn't work. But that is a strategy that becomes an anti-strategy. So let's teach parents, what do you do? When the child says, I don't like that, what we say is, we're learning about this food. We take them right out of liking and talk about learning. And we start with tolerating the food in the room. So that is visual. So if I have a child, and I do this with children who are 100% G-tube fed, gastrostomy tube fed, this is a strategy we use with them as well. We talk about the food. Look, this broccoli looks like a tree. This is green. Oh, I have a soccer ball. It looks like your soccer ball, but this is a cauliflower. Just getting them out of, they're going to make me eat it. That's my goal. Eventually, I'm going to get there. But can they even look at it? So maybe the first exposure, all you got them to do is look at it. Interacts with. Let's say they can look at it. That's fine. Interacts with. Can they do something to the food without touching it? So can we get them to help us stir the food, or put some food on their plate, or cut the food, or put it into a food machine and have it come out the other end? So I'm going to share with you some of these ideas in a different way in a little bit. So, okay, it's not about liking, it's about, look, we can change this food. Smelling. Oh, this has a big broccoli smell. Oh, this is a big spicy smell. Trying to help them move it closer towards their body. Touch. We talk about playing with the food, especially when we're in therapy. Now, in eating with the family, we may or may not be talking about touching the food, picking the food up with your hands, although Sarah talked to you about that using a utensil is very difficult for some of our children, especially with fine motor difficulties. So we do tell parents, if your child eats better with their hands than their fork, we will have some meals where eating with your hands is okay, and we will have some meals where we're working on utensil use. So touching the food. Can they touch the food? Touching it with your hands before putting it in your mouth is usually more effective. If it's in their mouth and they get a taste, then we start working on eating. So let me tell you, we all do this when we go to an unfamiliar place. So I went to China, and it was for a nutrition conference, and we were anywhere that I had ever heard of before. No English, everything was just Chinese characters, and I had to pick all my food by pictures. And China is interesting. They eat every part of the animal. And to me, I was like, oh, and it's always in a broth or a sauce, right? So what what do you think I did? And I know you've done it too, because I can see you smiling. So I picked the picture that I think I know what's in it. And in comes the food. What do? I look at the food. If you don't know what the food is, what do? You look at the food and you try to figure out what's in here. Right? Is there any food? Oh, this looks like green beans. That maybe looks like chicken. Okay? So I used my eyes because I had no experience with this. Interacts with. I took my fork and I moved food around to see if there was something in there that didn't look familiar. So I was in interacts with. I thought, okay, I think I know what's here. I pick up a little piece and it did not go in my mouth. It went to my nose. So I could get a better idea, what is this that I'm going to put in my mouth? So children need these steps if they've never had the food. You know what the food is, but they really don't. Then I usually took my tongue and just a little tiny touch and taste of the food. And then I would put it in my mouth. And there were times when it went in my mouth and I thought, I don't know what that is, and whoop, out it came. Because I thought that is not chicken. I don't know what that is, but I know it's not chicken. So when you think about going to a different country and you can't even pick food based on an understanding of the language, then you can understand these steps. That usually when I talk to families, I say, this is why we are going to break this process down for your children. So how are we going to help them go from no to working and interacting with foods? These are general treatment strategies that Dr. Toomey has developed. I've worked with Dr. Toomey since 1993, so on the SOS approach to feeding. So these are very these are very structured recommendations. And then I pick and choose based on the family that I'm working with. Where do we start? Because if you give them everything at once, they get overwhelmed. But these are some very simple, some new for families. Number one, use the same space and same set of feeding and eating cues. So there's a reason why when you walk past Starbucks, you want a coffee. Because the Starbucks logo and coffee are cues to having a coffee. Children need cues that help them learn to eat. We don't learn anything in a vacuum. There are influencing factors that help us to act in certain ways. So I'll tell you another adult example. I like using adult examples. I act differently when I go to a bar with my mother-in-law than with my best friend. My mother-in-law is a very powerful cue to act in one specific, very, very prim way. So the cues are always influencing us. We have, as an example, for children with gastrostomy tubes, parents feed children with gastrostomy tubes laying on the floor watching TV. That is not a cue to eating. We need children with gastrostomy tubes to at least sometimes, once a day or more, sit at the table with their tube feeding happening, even if they're not eating, with the other people eating. Because the cues of the food and the plates and the people sitting with you is part of learning how to eat. So we want to think about, where is the child eating? Are they eating at a table? Is the table a cue for eating? This is a little cartoon that reminds us that in most of our houses, the table is not a cue for eating. We do our homework at the table. We pay bills at the table. We have mail at the table, right? So for meal times, we want to take all of that off and put out a cue that it is now eating time. That will actually help your child move into behaviors of acceptance. I know that when I come here and the placemats are out, we're going to sit here and we're going to talk about food. Okay? Create a routine to meals and snacks. We teach our families that when you sit down to eat, there's a beginning, a middle, and an end to mealtime. Most of our families have no structure to the end. Most of our families battle with their children until the child decides, I'm done, and they leave, okay? Or the parent gets frustrated and they say, fine, you can be done, okay? We don't want children to, because that's reinforcing the child battling at meals. That is one of those desirable consequences is I get away from the table when I act this way. And so we want parents to be in charge of that. So we say we are going to have a beginning, a middle, and an end. The beginning is not, it's time to eat now, because none of us change course quickly. Okay? Usually if someone says, okay, you know, it's time to eat now, you wouldn't all jump up and run out the door. Although by 7 you might. Okay? Most of the time, you're going to need a little bit of time. Or if you are working at your desk and someone says, oh, it's time, you know, it's time to eat, you're going to say, in a minute, let me just finish this. So what we tell our families is, when it's time to eat, you're going to tell your child, okay, it's time to wash hands. In 5 minutes, it's time to wash hands. So we're going to give them a warning, and then the transition activity. So we don't want parents to fight about going to eat, right? The child is usually playing with their Legos, and they're having a great time, and they don't want to leave their play. And so we don't want them to start fighting about mealtime. So instead, we give them a warning, and we say, wash hands. That's our transition time. Good for hygiene, good tactile, hey? And most kids, at least, are not going to be as adamant. But if you're going to fight, then you're going to fight about washing hands. You're not going to be fighting about eating. And then we're going to sit at the table. In the middle is we are going to serve, and our preference is family style. So what is family style? It's where the food comes to the table and gets passed around, and everybody takes some from that bowl. Okay? Yes, it creates more dishes. But number one, as the food comes to the table and you start with maybe daddy, the child can see the food before it's right in front of them. So it's one is visual. As it comes towards them, if they will take some out, that's interacting with the food. So we are working up the steps to eating by starting with family style meal, okay? And then we're going to have a period of time to eat, and we're going to focus on the food, talking about the food and modeling with the food. And then the end is a designated cleanup. We teach our families you have to have a cleanup routine. So for us, the routine is that one piece of the food, unless it's a puree, one piece of the food you either throw away or you blow out of your mouth into a bowl or the trash. Our preference is the trash, a trash can. Why? Well, because number one, children learn very early, if something's in the trash, it doesn't come back out. So when I blow food into the trash, I know no one's going to ask me to pick it back out. That's why we use the trash. But some families don't like the trash. And so we say you can bring a bowl. Why do we have blowing it into the bowl as part of our routine? Because most of the time, the first time the food goes into the child's mouth is when they blow it in the trash. And so it's an opportunity to teach them that, okay, see, that wasn't so bad. Now, if a child can't get it to the mouth, we are going to say, oh, you know, it's okay, you can throw that in. Okay? Or they can pick it up with their napkin and throw it in. We go up and down these, we call them steps to eating. But our goal is always to try and get children to have more exposures, more visual exposures, more touch exposures. Now, common is a problem where the food comes and the child says, I don't like it. Don't put it on my plate. What did the parent do? We teach families we don't fight at meal times. It's never productive. So for children who can't have the food on their plate, we have what we call a learning plate. So if the child says, no, don't put that on my plate, the family can say, it's okay, it can go on the learning plate. And we put a new plate, a small little plate up in front of the other plate and put it there. And if they say, no, it's too close, we can take their plate and slide it away, okay? So it's trying to help them to recognize it's okay, it's not going to attack you, okay? So I will tell you, by teaching children the end routine, and we tell families when it's time to be done, you're going to say, okay, time to clean up. We use the words clean up. By teaching the child that this is what happens when we do cleanup, when they try to leave their chair, we just say, oh, it's not cleanup. We stay in our seats until cleanup time. And when they learn it, usually 3 or 4 times with the family, they sit down because they can understand, oh, it's not cleanup. I know what cleanup looks like. It's very effective. We want to create a feeding schedule. So we want parents to stop feeding kids when it's convenient for the parent. We want them to understand that feeding on a schedule, now we want to feed in response to the child being hungry, but we're talking about kids who don't know what that is, right? Who are G-tube fed and they don't really know that, or their hunger satiety is not well regulated. So we want to think about how do we teach them that hunger and satiety. So in the World Health Organization study, where they looked at children from different cultures, the mean age of introduction was about 5.5 months. Typical number of solid meals was 2 at 6 months, 4 at 9 months, 4 to 5 at 12 to 24 months. And they're thinking meals and snacks are the same thing, and in terms of counting them. So that's what we talk about too. It is not uncommon for typically healthy developing children to eat 4 or 5 times a day. Think about your 4-year-old. They eat breakfast, they go to school, they have maybe a mid-morning snack, they maybe come home and eat lunch, they might lay down for a nap and come up from the nap and get another afternoon snack and dinner. And some children get a bedtime snack. So about every 3 hours for many children, especially for our children who have poor skill or poor volume tolerance, the more frequently we feed them, the smaller the volume requirement is. So that's another piece of that. After about 16 to 18 months of age, we say every 2.5 to 3 hours during the daytime. Most children need to eat. And it typically takes us about 2 weeks of really being strict with this before the child begins to understand appetite conditioning. So we know that appetite conditioning is controlled by sensory inputs, by different mood, limbic, and cortical inputs, and then by visceral responses. And so we're trying to mimic that for our children that don't know anything about eating. Many of our gastrostomy tube fed children, the sensory inputs have not been in place. They're not getting the visual of food, the taste of food, etc. So we ask parents to present foods in manageable bites for the child's skill, not age. So a lot of times parents think, well, he's 4 years old, so I give him the kinds of foods that his 4-year-old twin eats. But this child may have cerebral palsy. This child may have trisomy 21. And so we need to think about what are the skills. You might still have to be cutting things smaller for that child's oral motor skills. We recommend 4 foods at any one time. Parents have a tendency to give too much to children and they just get overwhelmed. And we go by the guidelines from our country and your country. A protein, a starch, a fruit, and a vegetable are our goals. So ideally, if they are shown 4 foods every time they sit down to eat, they can start to learn about a wider variety of foods. And we tell families, start with about 1 tablespoon per year of age. So not a huge amount, not a big pile of these foods, but just a small amount. If the child asks for more, they can have more. And so just like your country, we have the fruits and vegetables, proteins of some sort, and then the grains of some sort. We want the child to be given at least 1 preferred food at every meal, because in family meals, we are relying on that food for intake. We are relying on the other foods for exposure, and depending on how restricted the child's diet is, they may or may not be eating the other foods on the table. We know that the food preferences of the parents are positively correlated to the child's food preference, and as I said, the most limiting factor related to a toddler's food preference is that the food was never even offered. So helping parents understand that there is a goal for providing those foods even if the child is not eating. Another big strategy, let your child spit it out, because otherwise you're going to fight about getting it in. When they know that if it goes in and they think, oh, they can spit it out, they're much more likely to try it. Okay? So choose how you want to deal with that. If you want to give your child a paper napkin every time they sit down to eat, and they could spit that piece into their mouth, that's fine. Okay? Or a little paper cup. Sometimes parents have preferred that. So that will greatly increase their willingness to try new things. Limit meals and snack times to about 15 to 30 minutes. Many of our families are trying to get their children to eat for 60 minutes. They're fighting for every taste. We're going to try and limit that. The research shows us that 20 minutes on average across a number of different ages is actually the average. Picky eaters take a little bit longer, but they're more like 23 minutes. And toddlers who are reported as having feeding issues, they're typically going over 30. Most of the time, what the parents are doing is they are fighting for every bite. So we want to change that. We're gonna be asking parents to try sitting down 5 times a day. So if the child doesn't eat a whole lot, they have another opportunity in 2 or 3 hours. Okay? Children with cystic fibrosis and 33 without medical issues, the mean age 18, the mean time for all children was 19 minutes. Even children with medical issues, with the right kind of structure, can eat in about 20 minutes. So we say up to 30 minutes would be okay. We just see what time it is. Okay. Social role modeling. This is probably the hardest for our families, is to sit down and eat with their children. But when we help parents understand how powerful that is, having family meals, we need to be sitting down and eating with our children. Model good eating behaviors. So we don't want siblings or parents at the mealtime to be talking negatively. And that happens a lot. I don't like that. The dad will say, well, what do you think the child's going to say? So this says, dinner's ready. Oh boy, What are we having tonight, Mommy? Leftover enchiladas. Yay! First one who complains sets a bad example. Being a role model stinks. But it's very important to be thinking about what we do teaches our kids. The child is not the focus. We have to teach parents to stop talking about the child because they spend the mealtime telling the child, you know, oh, you need to do that. How come you're not doing this? Why are you so picky? You know, just do it already, right? And all that's doing is creating stress for the child. Also, parents talk about everything else, how their day went, what the traffic was like, right? How awful the politics are. Maybe that's just the US right now. That's me. Okay, so all of that is stress. That's not helpful either. So we tell our families, no talking about any of that. At meal times, you talk about the food. You talk about what the food looks like, smells like, tastes like, where it's from, okay? You know, all of those things. We tell families, most of us eat with our lips closed because it's polite, right? But children have no idea what's happening inside your mouth if you don't show them. So again, if you have a child who's not eating well, open your mouth and show them how to do it correctly. So I have a video where I'm working with a child in therapy, and you'll see this here. There it is. Now, don't judge me, this happens to be jelly beans. This is a little girl with some cerebral palsy, and she mashes everything into the top of her mouth. And you'll see, she's trying to eat the jelly beans by sucking them. Okay? There is no real chewing. She's just like,
When you're out to the bathroom, you never know what we're going to have. Okay. You like pink? Up in your seat first.
Sorry, she's part of a little group of kids that we have in therapy.
Look. Okay, hands up. Oops, I need to put
See how she's just kind of...
There.
Okay, I'm going to put it on this side.
I have another one. Miss Kate took all of mine. So she'd have a whole big bunch of them. And I want them.
Can I have one of them?
Okay, so I'm on her,
Well, I think we can put one in.
her left.
One more for you. And chew it. I have three.
So now I'm starting to talk to her.
Okay, I'm going to chew it up. Hey, And let back me in. see. Let me see your teeth.
And I say, okay, open your mouth, let me
Chew.
see your
We're
teeth.
rolling around in the middle.
Because I'm
You gotta get
thinking
one
there
side of
is
your teeth.
no chewing
Nice
going on
chewing on
here.
your side teeth. There you go.
So I opened my mouth and I said, put it on your
Big
teeth.
on the side.
So I will taste the light.
Hey, let me see. Let me see. I gotta see if you squish
I'm
them.
asking her to see. She's still sucking more than chewing.
In the middle, honey.
I'm going to show her again.
Put it right here. Way in the back.
I said, I'm going to put it right here, way in the back on my teeth.
Move it over with your tongue. See.
Let me see.
Orange.
And then she moves it.
In your teeth?
So she has no idea. I mean, her mouth is doing this, but the food is not on her teeth.
Way in the back. Right back
So
here.
she
After you
drinks
let
her
go.
fluid,
These
or
have
her
to go in your
food.
tummy. You have to keep
We're going to
chewing
do it
first.
again.
Woo! Get it. Uh-oh.
So we're actually using jelly bean. This is in therapy. And in therapy, we actually use all kinds of foods. I've had avocado and I've brought calamari. I mean, we do have all kinds of foods. But when I'm trying to get a child to learn how to chew with their teeth, things like jelly beans, sometimes they stick. So if we can get it where it belongs and get them to bite down, then it's not rolling around in their mouth, and then we can actually talk more about where it is and how do we move it, how do we chew. And so that's why it's not a good example when we're talking about healthy foods, but all right. So obviously, we tell families they don't have to go to this extreme when they're imitating. But imitating the child's eating, when the child tries something, you can say, oh, you took a bite of your broccoli. I'm taking a bite of my broccoli. That is very powerful for children. They never get to be the center of attention during meal times in a good way. So we want to really catch them. And the power of role modeling is well known. We know that when an adult is sitting with the child, but they're not eating and we want the child to eat a meal, or if the parent is eating a different food, is not as effective as when the parent is eating the same food. So they really need to be eating the same food as the children, not a separate diet. Make the food fun. You know, there's something about going to a really nice restaurant, and when it comes out the food, the first thing we do is like, ooh. I take pictures of my food all the time because it's presented very nicely. So we tell families, take your carrots, take your cucumbers, take your vegetables, and do something simple with it. Even that, then especially with your 2-year-old to 5-year-olds, that in and of itself will really help you. Now, you don't have to be this elaborate. Hey, I'm like, wow, somebody really has time on their hands. It's beautiful, but so we teach families to do something like this. Very simple. Very simple, but then you can start talking about, ooh, I'm gonna, bite the toes off. Usually I don't do that with people-shaped items. Usually I would be talking about it maybe as biting the tops of the trees off if I was using a cauliflower. Children ideally are involved at all aspects of the meal as developmentally appropriate. Get our kids involved in cooking with us. It's one of my favorite things to do with my children and now my grandchildren. Kids need to stay at the table. If the child wants to get away from the table, A, have the end routine. B, teach the child to push the food away from them instead of them running away from the food. So if you brought something out, put it on a learning plate. Try to keep them at the table. Don't punish the child during meal times. Adrenaline will suppress their appetite. So there are fun gadgets out there now. The little girl on the left has trisomy 21. She is in a standing chair, and she is playing with some plastic food, and her mother gives her some of the fruits and vegetables to dip into the water to hand to the mom. So that level for someone like her. My grandson, actually, this is my grandson, who has a twisty vegetable peeler, basically. So all he does is just twist it and it comes out in rings. So thinking about fun ways of interacting with food. Reinforce the child. Talk about what they're doing. Be really positive. Wow, you're looking at your enchilada today. Just because so many times parents only reinforce when the child eats. So if you are at, I can't look at this food, your kids with gastrostomy tubes, start with when they look at the food, reinforce it. When they do something with the fork, reinforce it. Just comment on it. Just say, oh, look, Jimmy took a bite today. Don't make a huge big deal out of it either. Create a parent reinforcement value. Sometimes the parent and the child have gotten so negative around meal times that we actually teach parents they have to become a reinforcement once again. So we give parents sometimes activities like, okay, once a day you actually have to sit down and play with your child so that being with you is reinforcing again. Reinforce other kids at the table. It's why we have, in therapy, we put children with feeding problems in groups because they compete with each other. When you say, wow, Jimmy just took a bite of his chicken, the other child is like, well, look what I can do. I mean, it actually is very fun when you're running a group. Now, you have to be careful that parents don't use guilt, right? Look, Jimmy can take a bite, how come you can't? So we have to make sure that they understand how do you do that. And then as I said, if they're just looking at the food, that's fine. Playing with the food is reinforcing in and of itself, and touching the food can help a child who's afraid of the food to be less sensitive. So we sometimes use chopsticks. Chopsticks are not very effective at getting food in your mouth, but what children quickly learn is that they can either use it to stab with, or they get frustrated and they start to use their hands. So it's a way to get kids to touch if that's difficult. Avoid using preferred food as reinforcers. This is something that's a myth. People say if you eat your corn, you can have a cookie at the end. That is something that's done all the time, and it never works. So I'm going to come back to that in just a second. Not never, but it ultimately doesn't work. If you need to use something as a reinforcer, don't use the iPad. Don't use the television. Don't use the cell phone. What happens is the parents is if you eat, you can play with your iPad. Okay? Number one, they're not thinking about eating anymore, so you're not teaching them. Number two, if they stop eating, what do you have to do? You have to take the iPad back, and then they're going to have a fit. So instead, if you have to use something other than just talking, we suggest bubbles. You take a bite, I'll blow bubbles, because the bubbles show up, pop, are gone. You want more bubbles, you need to take another bite. But we don't use that very often in therapy. So this is a study of 66 studies. It's a review of 66 studies. Higher levels of parent pressure are associated with lower levels of child intake and weight and higher ratings of a child pickiness. The more a parent pushes, the more the child pushes back. Being rewarded for eating a food leads to less liking for that food. It is something called a valence split. So maybe I didn't really like corn, I really like ice cream, but if you start bribing me to eat corn, my liking for ice cream is going up and my desire to eat corn is going down. Because the way kids think is, if it's that bad that you are giving me ice cream, it's got to be really bad. And so they've done all kinds of studies where kids will come in and think, yeah, that food is okay. So they'll have them take food and say, I really like these foods, I really don't like these foods, and these foods are just okay. But if you try to teach the child to eat these foods that are just okay, using the foods they really like, the foods that were okay become sorted into the I don't like these foods anymore. So, and the last strategy is access the cognitive. Children are curious. Children are interactive, playful, and children have thinking. So we need to be thinking about how do we access that? What are the best ways to teach children? Because the way you teach a 2-year-old is not effective with a 10-year-old. So these are the stages that we talk about from Piagetian. Sensory motor is 0 to 24 months. So I'm just going to give you some very practical play strategies for each of these different ages. 2 to 5 to 7-year-olds, they think differently. They're in magical thinking, concrete operations. By the way, the older the child is who has not gotten any help, the harder it is to get them to change their eating habits. So, accessing sensory motor, your 0 to 2-year-olds, they do not have an understanding of what comes next. Their cognition is limited in part by their language. And so it's about what they can do right now physically. So we just talk about, look, orange, orange. to show them similarities. We talk about food in one-word labels, so nouns and adjectives. We talk about how it touched. We describe the food. We set out pieces and say, you know, big, little, medium. We say mommy carrot, baby carrot, right? They like to do things. We put things in and we take things out. So if I'm working with a 1.5-year-old who's 100% gastrostomy tube fed, a lot of my play is going to be things like dumping and filling and stacking things up and knocking things down as a way to teach them about touching and then about getting things to the mouth. Pre-logical, these are my favorite age to work with if I'm working with actual food. These are your magical thinkers. So your 2 to 5-year-olds actually think that mommies and daddies and, you know, things, they can think about this block is a daddy block and this block is a mommy block. So we talk a lot about magical play. We talk about, you know, these are trees instead of broccoli. This is a ball instead of, you know, broccoli. We use a lot of magical thinking. We start simple teaching about the body, about where the food goes into your tummy, and your tummy talks to you. We talk about food or, you know, hungry videos. There's a Winnie the Pooh video where in the video the little bear's tummy goes brrr, and that's his hungry. My tummy is hungry. And so when the parent has a rumbly tummy, we say, oh, get them to listen to your tummy and say, my tummy's talking to me. My tummy says it's hungry. We need to eat, and we sit down and eat, and then you have to bring them back to your tummy. And you have to help them to understand, and you say, oh, my tummy is happy now. So these are some of the more magical thinking. We talk about this food is like this food. So if the child has a preference, we can start to make what we call cognitive bridges. So look, you like French fries. This is a stick like a French fry. It's a white stick just like your French fry. But the French fry, you know, doesn't make noise when you bang it on the table. This does. This is a parsnip. Okay? So I'll bring in vegetables and cut them similar to their preferred food so that I can help them to understand it's just food. They just don't know what it is. So a parsnip is like a white carrot. And now we have white carrots and purple carrots, and then turn the new food into something familiar. So we may cut it into something that's a shape that they know. Concrete or logical children. These kids are rule-based. So if they're in the 7-ish year to 9, 11-year-olds, we set up all kinds of rules around eating. We talk about things like, your body gets energy for play. Because when you ask a 10-year-old, why do we have to eat nutritious foods? They're going to say, to grow big and strong. Okay? To say what they've been told their whole life. Okay? So instead, we say yes, but really so you have energy to play. Because that's what they care about. So then we set up rules. And the rules may be, when you sit down to eat, mommy has to give you at least one food that you will eat. Okay? And you can decide if you do not eat at that mealtime, there are only 2 ways that we get energy for play. One is to eat, and one is to lay down. And when you lay down, it is no iPad, no TV, none of that. It is rest. And children hate to be bored and to rest. And so then eating is more preferred, right? And so you're not fighting about it, it's just a rule. You know, and these kids fall into rules very quickly. We have rules about we're not boring, and so we don't eat the same food every day. And so if you've eaten your Cocoa Puffs for breakfast, then you can't have Cocoa Puffs for 2 days. That's just the rule. And they're like, oh, okay. I mean, it's very interesting. You can't do it with the younger, and you can't do it with the older, because the older child in formal operations is now fighting back. They have learned all the rules, and they're breaking all of them. These are your teenagers, okay? And so here, we move into thinking like scientists. So the way that we work with these children is very different. We do experiments. We teach them that, okay, if you don't like this food, you can change it, okay? Because going out to restaurants, a lot of us know that you can ask for, I want the hamburger, but I want the lettuce on the side, or I want this over here. And so we teach them how to do that. We actually do field trips with our teenagers to different restaurants, and we teach them, okay, how do you manage your reactions while we work on skill? Because we're just trying to get them out of that automatic no. So part of it is also food choices, giving them some handle around that. So with both of our concrete thinkers and our teenagers, we start talking about, okay, every time we sit down, we need to have a protein, a starch, or a grain, a fruit, and a vegetable. But they get to start picking. We have them go to the grocery store, and they get to start making choices. So they have the rule that they have to live by, but they now have some ability within that rule. So remember that kids are picking foods usually that work for them. And work is not just the physical, mechanical, it's also the sensory feedback. So like I said, yes, there are fats and sugars out there, but we break everything down. It's a protein, a starch, a fruit, or a vegetable. The other thing we start doing is teaching parents to cook foods to make it easier for their child. So we talked a little bit about products that you can buy. We also know that things like meat, if you grill it or you put it in a broth and you cook it all night long, it is very different to eat, right? When you stew a food, it's much softer than if you grill it. And so we start teaching parents, this is what your child can do mechanically. And so how do we take the food and change the texture by cooking it in different ways? And we tell families, it's really okay to eat your food separate. And we teach children they can take their sandwich apart if they don't want to eat it together. It's really okay. One of the nice things is that sometimes the strategies we teach the 8, 9, 10-year-olds, like taking their foods apart or saying I don't want this or I don't want that at a restaurant, actually go away when they're teenagers because then they have the skill, they've learned about these foods, and when they go out with their friends and their friends are not taking all of their pizza apart and eating it separately, that peer pressure sometimes helps them to make that last step of eating foods that are going together. We've already talked about breakfast, lunch, dinner, snack foods. Our goal in therapy is to teach children to eat not processed foods. But the reality is that we all eat some processed foods, most of us do, and so, we just try to think about, okay, that processed food is almost always a grain. So if you're having potato chips, you need to have a fruit. That's just the rule. Potato chips and a stick of cheese and a handful of blueberries. That would be a snack. So working from the foods that the child likes, we build the skill. So that's what we're doing in therapy as therapists, trying to figure out what skill does the child lack and how do we build that. And then The last kind of idea is in terms of thinking about what the child is eating. Children who prefer those meltable cookie, cracker, squishable foods, look to see if they're moving their tongue side to side and if they're putting the food in the right place. So I'll tell you one thing that that you can do, or if you want to, I don't know how much you want to do of this in your own practice, but I personally like either things like a jelly bean or the mini Oreo cookies. Do you have mini Oreos here? Yeah. So I'll give a child a mini Oreo cookie and I'll say, oh, here, you can have this. They usually are like, oh, hey. And then when they're done, I say, open your mouth, because Oreos leave black residue. If there is no black residue on any of their teeth, they are not chewing their food. So that's a kind of very quick way to just get an idea of that. So those are some reasons why we would use sweets, is to be able to track where did that go. I'm trying to think if that would be helpful. Okay. If children like the grains over the fruits and vegetables, oral motor skills, like I just talked about, consider flavor preferences. A lot of your grains are very bland foods, and so fruits tend to be more sour as well as some sweet. Vegetables tend to be bitter and sour flavors, and so they may need some experience with those. Consider adding flavors to help counterbalance. So if the fruit is really sour to them, maybe using a sweetened yogurt to go with that fruit to kind of dampen down that sour, as an example. Vegetables, the people. There are people who have kind of heightened reaction to various vegetable flavors, and they have an actual genetic difference that causes that flavor to be really big for them. And so things like dipping it in a cheese sauce can sometimes bring that reaction down. So hopefully this has kind of helped us to think about these kids a little differently. We didn't spend as much time on kind of the medical complexities of how do you work with children with dysphagia, how do you work with children with really motoric involvement, because trying to do that in 4 hours is really challenging. But I like this quote, because so many times when a child isn't eating well, actually for children who have tube feedings, sometimes I think we understand why they're not eating very well. But for a lot of other children who are eating poor diets, we think it's just behavior. So what we believe impacts the decision-making process for treatment. If we believe that the child has an emotional or behavioral problem, we'll try to control and fix the child. If we believe the child is having a stress response because they cannot manage the task, either because of learned behavior or poor skill now, we will teach the skills in a manner that respects the child's readiness for the task. We'll start where they're successful, we'll work on building skill, and we'll work with the family and help them to understand the process as well. So the goal is to get kids to eat pretty much anything we put in front of them. And that, hopefully, we've given you some ideas on how to make that happen.